call the April Board of Health meeting in order. For the record, there's a copy of the Open Meetings Act over here on the north wall of the legislature. And just also, if anybody needs to know, there is an automatic defibrillator in the back of the room if anybody needs it for any purposes. There's an official copy of the publication for the Daily Record. And with that, roll call.
Wade. Here. Festerson. McNally.
Here.
Rogers.
Here.
Weiss. Jones. Wilkin.
Here.
King. Espinoza. Okay.
Item 2 is approval of the minutes of the February 21.
March.
Should be March of the March meeting. Is there a motion to approve? Motion by McNally. Is there a second?
Second.
Second by Wilkin. Roll call.
Sorry, just making sure I got everything. Okay. Wilkin.
Yes.
Wade.
Yes.
Rogers.
Yes.
King. Jones. Weiss. McNally.
Yes.
Espinoza. Okay. And Festerson.
We'll go to item 3 in approvals of actions. We have items A through N. I will ask for approval of items A through N with the removal of G because I need to abstain. Is there a motion to approve the A through N with the removal of G?
It means A through S.
Excuse me. You're right. A through S. Sorry. A through S with the removal of G.
So moved.
Motion by Wilkins. There second. Second by Wade.
Okay. Hang on. Okay.
Any questions? Roll call.
Festerson. McNally. Rogers.
Yes.
Wilkin.
Yes.
King. Jones. Espinoza. Weiss. Wade.
I'll entertain a motion to approve item G. Motion by McNally, second.
Second.
Second by Wilkin. Roll call.
Espinoza. Festerson. Jones. King. McNally. Rogers.
Abstain.
Oh, abstain, sorry.
Nope, you're all right. I need your record.
Wade. Weiss. Wilkin.
Yes.
Okay.
We'll go to item 4 and the Health Director report and other issues of discussion. Dr. Hughes.
Good morning. I only have a couple of updates for you today, and I'm going to move through those so that we're able to move on to some of our guests who we're working with a schedule in Lincoln. So we want to make sure that we get them up and on their way in a timely way. So the first thing that I wanted to update you on this month is that we were able to submit our accreditation documentation package in full at the end of March. I think it was March 26th. If I'm not mistaken, it was even a day earlier than we had made our goal for, and that actually was 5 months earlier than the actual deadline that FAB had set. So we are very excited about that. It's the furthest we've ever gotten in this process, and I really, really need to just recognize all of the people who were a part of that. This has been a really long and sometimes an arduous process, and our accreditation coordinator has worked incredibly hard to kind of pick up where we were and continue carrying the ball. Jamin Johnson, our Chief of Health Equity and Planning, was also extremely instrumental in that process as we were between accreditation coordinators. He was able to keep our teams engaged and moving with their work before we had another accreditation coordinator hired. Very grateful for our previous accreditation coordinators who also moved that needle where it needed to be, and all of the people who served on accreditation teams. So previously, this effort was really undertaken at the management level, and we made the decision that since this is really a process that's supposed to celebrate and kind of toot the horn of the whole department, we wanted the whole department involved. And so a number of our supervisors and staff also were involved on these teams, gathering documentation that met the standards, doing annotation. So basically they have to go through every single document and kind of pull out the pieces and note the pieces in the documentation that meets those standards that we're trying to reach. And there's a very specific format all of that has to be done in, and it can be quite a heavy lift for some of the teams. And so we had 10 domain teams that worked really, really hard to get all of that done, and we're so incredibly proud. So the next steps for this is that we, right now, our documentation package is being reviewed, and then we will have a couple of accreditation specialists from FAB that will actually come do a site visit. I think we've brought this up a couple times now in Board of Health, but I would anticipate that some of you may be contacted to have interviews by those FAB team members that will be coming for the site visit. They'll be here for a couple of days, so it's a pretty intensive 2 full days for that site visit. And then after that, they will go back, deliberate with all of their information, and make a decision. So we are still a little ways out from actually seeing that accreditation, that plaque that we can hang up and you know, the notification that we can put on our webpage and all of that. But we are so proud to have gotten to this point and are just very grateful for all of our staff who were so instrumental in that process. I also wanted to let you know that our incredible budget people have completed the budget, and that will be going in hopefully later this week. There are some technical difficulties that the county is having with the software that all of that information goes into. Our budget manager, finance manager is very involved in a lot of communication with the people who need to get that sorted out with that system. And we do anticipate that everything will end up going in smoothly. We were able to meet our budget goals. So basically the goal that the county gives us to shoot for, we were able to be on track with that. And even better, we were able to cover all of our positions, including the few that we have open. So we are very, very happy to have that done. I also just want to shout out to Jerry McKay and her team for their hard work in that process. It's always very stressful. And actually, that's why Jerry is not here today, because she is actually back at the office working in Hyperion, trying to get all of the reports to be correct because the software is not working well. So I wanted to make sure you all were aware of that, and we're glad to be over that hurdle. And then I just wanted to let you know that next month, I don't typically point out to you the upcoming month's agenda, but I did want to let you know because it does happen a little bit later in the year now than it used to. Next month will be State of Public Health, so definitely you'll want to be here for that. And you can look forward to a somewhat new format with that. We are kind of in a transition with trying to make that as informational for you as humanly possible, give you and the community as much information as we can with that in the way that tells our story best. So we're really looking forward to that as well. I am going to hold off on a legislative update because tomorrow is the last day of session. And I will do kind of a full overview as we move into the State of Public Health presentation next month. So I'm going to hold on that. And with that, I will see if any of you have any questions for me today.
Dr. Hughes, I'm curious, so while you're there on that, 570, I looked on the site, it's in the report as it got out of community, but it didn't look like when I looked on the legislative website and looked at 570, that's the, I'm slipping the bill, but it's the bill you wanted to get for the data piece.
Okay. Do you want to speak to that?
Is that, it didn't look like, when I looked at it, Has that gone through? When I looked at it, I didn't see it on there as passed or anything like that. It notes on here that it got out of committee, but is that crossed the line or is close to?
I will look. I can't answer that question right now.
Okay.
But I can definitely look it up and give you an update on that.
Yeah, I'm just wondering, because if that's the case, then I guess you're going to go at that next year?
Yeah.
All right.
Yeah, there were a number of bills I know that weren't going to make it through this year, so it wouldn't surprise me if
Okay.
it did take another year for us to
Okay.
work on that.
All right. Yep, that's what I was. Okay. Seeing none for anybody else?
Great.
Okay. All
We'll
right.
move forward.
Let's transition to presentations, and are you taking the lead on those first two? Okay.
I am going to start with one, and I think we're maybe in search of the others. And if they're not here, I will talk to them. So last week was or maybe it was the week before. How long ago was it now? 2 weeks ago. Time moves really fast for me. The Public Health Association of Nebraska held their annual conference in Lincoln. And there were a number of awards that were presented at that conference, and there were a few of our people who got awards who were not able to receive them there at the conference, and so we thought it would be really nice if we could perhaps recognize them here today. So I am going to start with Caleb Cudis, who is one of our ERCs, and I'm going to ask Caleb to come up. And I'm actually going to ask Jamin to come up too. So Caleb received the Outstanding Student of Public Health Award. He is working on his doctorate, right? Master's and then doctorate. He's on the track. And he is an incredible student, along with being an incredible emergency response coordinator. The work that he has been able to accomplish for us in the short time that he's been with us has been absolutely incredible. And he puts, I'm sure, as much into his schoolwork as he does into his work. And in fact, we've seen as he's moved through his schoolwork that, he really takes what he's learning in the classroom and applies it really well to his work with the department, which is, of course, really amazing. And I believe he was nominated by Jamin. And so I am going to give Jamin a moment to talk about his nomination because I don't have the text for that. They did not send it to me.
Sure. So one of my other privileges is to actually sit on the the Public Health Association of Nebraska's Board of Directors. And so we were able to nominate some pretty amazing and outstanding public health champions throughout the state. And one of the awards that is presented annually is the Outstanding Student Award. And I could not think of a better person when asked to consider nominations than Caleb. So Caleb is a full-time MPH student at UNMC. He is a full-time dad, which is many of us know what that entails. He is also a pretty outstanding addition to our team at DCHD. We have been rocked, as you all know, with unexpected public health emergencies, and he has either led or supported all of those, and it has been pretty amazing to watch, and he has strengthened the work that the rest of us do. So being able to nominate a colleague and an amazing public health practitioner for this award came pretty easy to me, and it was also wonderful to see that there were two other people on the FAN board that also recognized and were considering nominating him. So it was an easy vote to award him this year. And after that nomination, we found out that he had been accepted into a DRPH program at UNMC. So he decided that he wants to continue on, even though we've put him through his paces. So we're pretty excited.
All right. So, put this give you, and I don't think we have any cameras here because our PIO is out today, but Jamin has it, so we have to look like we're official here. Handing it over to you. This is good. Hey.
So let me ask you, you said he's a full-time employee and a full-time student?
Yes.
So, I mean, does is Grasshoot full-time, 12 hours?
I think it is. I think full time is 6.
Or is it
isn't
6?
6, yeah.
Okay, no. I was
Yeah.
oof. That's a month, yeah.
Do you have
got,
anything
you
you'd
got
like to say,
kids and
Caleb?
you full-time
You
and
don't
your dad, that's a push.
I mean, all I can say is thank you. It's been a pleasure working at Douglas County Health Department the last couple of years, and being able to be a student at UNMC and still work full time at Douglas County, both experiences enrich the other to the fullest extent they possibly can. And I'm just looking forward to continuing to work at Douglas County and hopefully finish up my degrees there. So, thanks.
Thank you.
All right. And we have found our people. So, sorry to have you sit down and then come right up, but I'm going to invite our friends from the state to come up to award a couple of our community health workers. Also received recognition at the Public Health Association of Nebraska conference a couple of weeks ago, and we're just a couple words before they come up. So proud of our community health workers. I know they've been up here to tell you a little bit about what they do and kind of what their areas and programs look like. But I have to say, I am so incredibly proud of just the passion that they serve their populations with, and just the energy that they bring into public health and just their heart for service. The creativity that they have to, come up with the right way to serve populations is really, really incredible to watch. And so, we kind of think of our community health workers as our foundational public health workforce. And we're just incredibly proud of them. So I'm really excited that 2 of our community health workers were honored this year. And so I'm going to go ahead and invite our friends on up to present those if possible. Great, thank you.
Thank you. Good morning. My name is Karina Rodriguez. I am a community health worker, and I am part of the CHW Collaborative, which is in part working with the Department of Health and Human Services. And what our goal is, we are actual community health workers, and we're trying to make it a sustainable workforce for Nebraska for community health workers. And we are also trying to provide training for community health workers and establish like a model for training for community health workers here in the state of Nebraska. So we know how much work there goes into community health work, and we wanted to recognize some amazing community health workers. So we sent out awards or information to nominate community health workers, and we received multiple nominations, but I wanted to share or congratulate the ones that will be receiving awards today. They are doing some amazing jobs. So we're going to first go with, okay. There was 3 categories for community health workers awards, and the first one we're going to do is called Making a Difference Award. And this is recognizing a CHW for a strong performance in the areas of leadership, teamwork, and or dedication to serving the community and its members. And it can be nominated by a CHW, community member, employee, or by anyone who desires to recognize the work of a CHW. And for this award, this was nominated by Lindsay Hughes. I'm hoping I pronounced that correctly. Okay. In the past years, Douglas County Health Department and other areas health departments have indicated that mental health is the greatest priority health concern facing our communities. However, public health has sometimes struggled to determine our roles and activities in this space. Community health worker Jordan Cedillo, along with his supervisors, determined that reducing youth stigma around mental health might be possible if teens understood that therapy doesn't always mean sitting in someone's office crying. To address this, Jordan built a pilot entitled Project New Lens. The pilot program took 9 youths from North Omaha and introduced them to alternative mental health therapies, including art therapy, ecotherapy, and equine therapy. Okay, perfect. Thank you. Throughout the sessions, the kids were taught a variety of coping techniques, including mindfulness, creative connections with animals, and with nature. Evaluation following the pilot revealed that the kids were engaged and had learned new ways to take care of their mental health. Jordan is now working to find funding and expand the program into other areas of Omaha and to include even more therapies. Jordan's passions, creativity, and drive helped us to take a big step in thinking about how we can serve our communities by destigmatizing seeking out mental health therapies. He also showed outstanding leadership through his ability to seek out and build great partnerships with organizations and therapists in our communities, relationships that will only enhance our ability to impact the public's health. We are very excited to see where the New Lens project goes under Jordan's leadership, and we are grateful that he is part of our team. So, Jordan, we have this award here to present to you, and we're just super impressed by the work that you're doing. So we're just really grateful that you're doing this job. So
thank you very much.
Thank
Appreciate
you.
that. Thank you. Thank you very much. Thank you
so
very
much.
much.
Oh, here. Sorry.
Perfect.
And we'll
Make
skip.
sure it's safe.
Yeah. We also have something else for you, so.
Okay.
Yes. And then this next award is going to go to Lulu for a CHW Outstanding Service Award. So the description of this is recognizing a CHW who has gone above and beyond the service to serve the community through initiative and the creative means of reaching the most underserved groups and communities. This individual passionately works to mitigate barriers to better connect our most vulnerable community members to supportive resources. So these are the words from Natalie Kingston, who nominated Lulu. Lulu immigrated to this country from Burma, fleeing for her life. She knows and has experienced the trauma and many of the challenges families face coming to the United States from a foreign country. Think about not speaking or understanding the primary language or how to begin to access resources. You can't get around your community due to the transportation barriers, you don't understand the busing system, and you aren't able to get a license until you learn the language and can pass the driver's test in English. Affordable housing and job opportunities are scarce. If you experience any health issues, understanding the healthcare system, having insurance, and trying to connect with a primary care physician who doesn't understand your issues nor speaks your language is frustrating. Everywhere you go in your community, no one understands you or what you need. So Lulu has become the primary gatekeeper for her community. People reach out to her day and night for help, for everything from newborn questions from young mothers, parenting issues, legal assistance, landlord challenges, you name it, Lulu has helped. Lulu's role as a community health worker at the Douglas County Health Department has evolved from providing education, awareness, and assistance to the Burmese and Karen communities during the pandemic to working with our LEAD program, providing translation for Burmese and Karen families living in potentially run-down old housing areas with high lead levels. Lulu participated in a raccoon bait distribution due to an unusual rabies case. Lulu's involvement in her community increased her awareness of chronic conditions, especially diabetes. Lulu went through training in 2022 to become a diabetes prevention facilitator and successfully launched 2 DPP programs this past year in partnership with One World, targeting the Burmese and Karen communities. Lulu spent hours translating the DPP curriculum, which is not yet available in Burmese or Karen, so her community could understand the risk factors associated with prediabetes. The DPP curriculum focuses on healthier choice foods and exercise and help participants make small changes to reduce their overall risk. TPP is a 16-week evidence-based program that meets monthly thereafter for up to 1 year. Lulu continues the partnership with One World to provide monthly maintenance classes and exercise opportunities. Lulu went through Living Well training to become a Living Well facilitator at the end of this past year. Chronic diseases are impacting her community, so Lulu felt it was also important to provide education and classes to help those struggling, helping participants adapt and learn how to better manage their chronic conditions long term. Living Well is a 6-week evidence-based curriculum designed to help individuals manage their chronic conditions to live their best life. The curriculum is also not available in Burmese and Karen and will require translation hours to accomplish. I would like to end the fact that Lulu is the most humble and kind person you will ever meet. She doesn't seek recognition for her tireless work. She does it as it just comes naturally to her wanting to help others. So we wanted to also present this award to Lulu for her amazing work. Thank you. Thank you so much. Congratulations. So thank you so much for allowing us some time to come and present this awards. They are doing an amazing job out there as community health workers. So thank you.
Thank you. Let me ask you, what's your role again with the state?
My role, I work for DHHS, the Maternal and Child Health Program. Some of our funding for the Community Health Workers Collaborative comes from Title V funds, which is what my program works with. So I was hired at DHHS a little over a year ago, and I was pretty much thrown into these Community Health Worker Collaborative meetings that I did not know what I was doing at all. But now that it's been over a year, I can't believe that I never knew what a community health worker is, and I'm so glad to be able to learn from everyone in the collaborative, and I would say even become friends with some of them. They're absolutely wonderful people.
And I'm a current community health worker. The collaborative is only made out of community health workers that are actively working in the field, except for JC and the leader Jessica. So yeah, we are currently working. I work in a clinical setting, but all of the other community health workers work in different areas, and it's also across Nebraska. So again, our main role is to try to build a sustainable workforce of community health workers for Nebraska.
Can I ask if we can, not May, but to give it time, the June, the committee meeting that happens on the first Friday, can we set that up because I'd like to get an understanding of what that Community Health Worker Collaborative does.
Yeah.
That way they could set it up Zoom and be in Lincoln. I'd like to get an idea, a deeper content of where that is with the state, how to
Of course.
work
I can also send you PDF versions of the flyers and brochures that I use when we go out to conferences, which is only one thus far, but hopefully many more.
No, you can send it, but there's like a Zoom committee meeting that we have once a month is needed, but I'd like to hear a little more in detail and then give the board members who want to listen in an opportunity and possibly, other community health workers, if they're free to tie in. I'd like to get a deeper understanding of this and go just to get an understanding where the state is on this and how they see it.
Sounds good, yeah.
June. Give them some time because I don't know who you all may need to coordinate with on your side. So.
Yeah, we would need to coordinate with a couple of different members and Jessica. It's just to make sure that everything should be fine for that day. But yeah, that would be really great, so we can just kind of share exactly what we're doing and how we're doing it. So.
Thank you for your service. Do you happen to know how many community health workers there are across the state?
I don't have that figure on the top of my head. That's something we can definitely figure out. I know that, we have trainings that are being completed through UNMC and Creighton. However, how many of those people are actually actively working as community health workers, I'm not quite sure, nor how many are actually employed. So.
Okay, and Do you know if all of the health departments across the state have at least one community health worker?
I think definitely, I think most of them do. Some of the members in our collaborative are working with the state and their different counties, so they definitely have community health workers. How many don't? I don't have that figure as well, but that's something we can definitely provide for you, maybe at the next meeting that we have. So.
And last question, is there ongoing funding for positions for community health workers in all of the health departments?
So right now, most of the positions for community health workers are grant funded. There are some, like with Community Alliance, that are able to bill insurance for their work hours. We're also trying to get that. I believe it's something based on the legislative structure of Nebraska that doesn't allow for payment from insurance companies for community health workers, but I think that's something that we're actively trying to change and advocate for. Mm-hmm.
Thank you, and Jordan and Lulu, thank you for your work. I mean, I know, particularly when, we got the grant and started it, you all have definitely stretched the boundaries and opened up new ways to use the position, which I'm glad for, and want to encourage all of you all to keep pushing it, because I think it's just a lot of potential in that position to do it. It's like a Swiss Army knife of the positions. You can do a lot of things. Appreciate it. Congratulations. Thank you all.
Thank you.
All right. Let's go to item C, the I Heard program from UNO. Anybody see?
Make sure I actually share the screen. Okay, so good morning. And I would like to welcome Dr. Ayo, who is from UNO, and we are excited to have her present on I Heard, which is a health misinformation monitoring and response system. And I will let her give the details on kind of how it started and how we ended up setting up something here in Omaha. So, come on in.
Good morning. Thank you for the opportunity to do this. Okay. Yeah. Oh, okay. Yeah, thank you. So first of all, I'm grateful for the privilege to be here. I'm also happy because I have an opportunity to thank the Douglas County Health Department for the support they've given to this project. The I Heard Omaha project is a health misinformation monitoring and response system. So the goal is to track the spread of health misinformation in the community and to respond to it by providing accurate corrective messages. Why is it important to track health misinformation? So we realize that behavior change is often predicted by exposure to misinformation. If I hear that this particular health procedure would kill me, I probably won't want to do it. So the possibility, if we want to influence behavioral outcome, then we probably have to think about the information that people are exposed to. So what is I Heard Omaha? 3 major things that we do. We monitor the spread of health misinformation. We report our findings in a timely way.
So, Doctor, can I just stop you if you can? If we can we minimize that box and move it up so people online can see the full piece?
Oh, okay. Yeah.
Thanks.
Yeah, thank you. So 3 major things that I Heard does. First, we want to track exposure to health misinformation. So we monitor the spread, then we report our findings, and then we respond by providing accurate health information. A little bit about how we monitor it. Every week we send out a survey to about 120 Omaha residents, and we do this every week. And we're asking them 3 major questions. Number 1, have you heard this particular misinformation? So we say something like, in the last 7 days, have you heard, seen, or read? And then we insert the particular statement. So we're tracking exposure to the misinformation. We're also asking how well do you believe it? So we're tracking believability, and then we're asking where did you hear it from? So we're tracking the source. We're able to use these variables to calculate the threat of that misinformation. So if a particular health misinformation has high exposure rate, meaning a lot of people are hearing it, high believability, meaning many people believe it, we rank it as high threat. So we're able to use all those variables. We also have two major questions we include, which are usually open-ended. We ask, what else are you hearing? Aside the things we've asked you. We also ask, do you have any message you want to share with the city leaders to help make our city better? So we collect the data, we do this every week, and then the next thing is we report our findings. We do a rapid analysis, we report on a public-facing dashboard. An example is what we have here for one of our items. The dashboard shows the trend in exposure, it also shows how well people believe it, and it also shows the sources. We also send our reports to DCHD every week. So far, we've done for 32 reports, so this has run for 32 weeks. Every week, never missed a single week, Thanksgiving, Christmas, New Year. We do this every week. Here are some interesting findings from some of the surveillance or tracking we've done. For example, when we asked about, have you heard that ivermectin can prevent or cure COVID? This particular misinformation claim ran for about 13 weeks before coming down. Some other ones, like the natural immunity claim, ran for 23 weeks before coming down. So we're able to track the lifespan of health misinformation in the community. We're able to track how long it takes to spread, to mitigate, to intervene, and for it to come down. We're also able to look at demographic differences in exposure to health misinformation, and to also see demographic differences in how well people believe it. There are some times that you hear a particular health claim, exposure may be low, but among a particular subgroup, it may be very high or high believability. So an example is the ivermectin claim, where about 26% of African Americans believe it, compared to less than 5% of white who believe it. So sometimes there is a disproportionate exposure or believability to health misinformation. And all of these have, they predict certain behavioral outcomes. So like I said, first we monitor, we collect, next we report, and thirdly we respond. So we want to respond, we want to produce accurate health information, we want to produce corrective information. We do this in two ways. We do this every week. The first thing we do is we send out a newsletter or alert to trusted local leaders who are already registered that they would like to receive weekly information. So we tell them, hey, this is what we're hearing this week. These are the resources you can use to respond to them in your community. Next, we also use social media. So every week we produce health communication resources that we share on social media, mostly informed by the surveillance system. So kind of informative. A little bit of the results we've had so far. Like I said, we have about 120 participants. We've been able to run this for 32 weeks. We started August 2023. So far, we've had about 2,007 responses from our surveys. We have 82% response rate, which is quite high. I mean, for a longitudinal study that's been running every week. Participants do receive $10 when they complete the baseline survey, and then they receive $5 every week when they complete the weekly survey. So far, we've had about 6,620 plus views on social media across all different platforms. We've been able to send out 200 email alerts, like the newsletter, to local leaders, alerting them of what we find each week. And we've had about 142 health communication resources that we have distributed. A little bit about the description of our panel members. Who are these people that answer the questions? We were very intentional about amplifying the voices of minoritized population. So about 38% of our panel members are from North Omaha, about 23% from Northwest, 22% from Southwest Omaha. We have about 43% who identify as white and about 20% as African American. So there is intentionality about representing voices that probably may not have been heard. over the years. I also wanted to share this. One of the open-ended questions we ask is there anything you want to tell Omaha leaders to help make our city better? And this was the result for last week. So we collect this every week, and we have people put in thoughts. For this particular result, about 85% of the people said, we have nothing to say or everything looks good. But among the 15% who said there is something to say, we try to stratify by region, and you could see that there is a high entry, like 54% from North or Northwest Omaha had something to say, like had a message for the city leaders. This sort of suggests that when given the opportunity, people that are often whose voices are not heard would probably take the advantage and want to share something when they have the opportunity to. And you could also see differences in the issues that were raised. For example, there is high emphasis on COVID prevention and gun control issues among people from North or Northwest Omaha. However, in the South, Southwest, we have issues around immigration, mental health, hand sanitizer, and a little bit. So this system has been able to demonstrate that there are differences in how people in information need. What information work for these people, like the information they prioritize at a particular time may be different from what another group would prioritize. And finally, I just like to talk about the future that we see for I Heard Omaha. The current funding we have would end August 31, so we're hoping that we're able to run this system for another year. Also, we also want to increase the distribution of corrective health information. We want to build more collaboration with community health workers to help us distribute this accurate health information in the community. We've been having some sort of synergy. The community health workers really help us with recruitment. They also help us with distribution, but would like to see that expand. We also want to provide free health resources that are localized to community organizations. One of the feedback we get from the community organizations we work with is that many times when they're looking for health information, they don't find local resources. Like they have to go to the CDC website or the FDA website to sort of download, but they want something templatized for Omaha with Omaha data and all of that. So we've been offering branding services. Sometimes they ask us to put their logo on it so that it's sort of localized, which is something they may not have been able to do if they're just downloading from the CDC website. They've also expressed some of the limitations they have. Many of them don't have in-house graphic designers who would design stuff for them rapidly. So they use our system and we are able to give them, customize our resources for them. We also hope to increase health information monitoring around topical health issues. So for example, we want to be able to support what the city is doing and say, hey, we want to track the spread of health information around cardiovascular issues, around mental health, around adverse childhood experience. We want to track the spread of health misinformation around topical issues. We want to support community leaders by providing the data that they need. We want to be able to use I Heard more synergistically with what the city is doing and provide important data. Some months ago, the CDC reached out to us when they were trying to release the updated COVID vaccine. They asked us to ask our panel member what name would they prefer that the vaccine to be called. Should it be called updated? Should it be called booster? Should it be called? And we asked our panel members, and a lot of people voted for the updated. So we sent the message to the CDC and said, hey, this is what people think the name should be called. So we want more of that. We want our data to inform decision making at every level. And finally, we want to expand such that we want to have, I heard, health information intelligence across states. So if we're hearing this health misinformation, is it just peculiar to Omaha? We want to collaborate with other states and say, hey, are you also hearing these? What can we do? How can we work around this? I heard started in St. Louis, Missouri. That was the first ever. Next, it spread and expanded to Omaha. Right now we have I Heard Colorado, I Heard Texas, I Heard Baltimore, and before the end of the year we'll be having New York and Georgia also join the I Heard system. So the goal is to keep expanding this, but then different states have different things. For example, for Colorado, they are very particular about cardiovascular health. So the I Heard is sort of focused on cardiovascular health. Baltimore is more interested in Hispanic population, so a lot of their panel members are Hispanic population. So we're trying to build that system to track the spread of health information and quickly address them. A lot of this is being done on social media already, but then we are one of the first doing this hyperlocal where we go into the community to ask community members, and we also target people who do not visit the internet. So we are still able to capture hyperlocal health information spread in the community. Thank you. $32 weeks. So we started 32 weeks. Yeah. Did you say budget? The current budget is about 92,000.
Sorry. What's your budget number?
92,000.
Okay.
For 1 year.
Can you? I don't want you to give it out now. Can you share with, I guess, Dr. Hughes, Alina, what's your source? Because you say you're getting out in you don't know what you're doing next year. I don't know if you feel comfortable doing that. Okay, go ahead.
So we were fortunate.
State your name for the record.
Oh, Leah Kaznave,
Okay.
Division Chief of our Community Health. So we had received funding through Creighton's Community Collaborative,
Oh, okay.
and that helped support this system. And so now I'm touching base with some of our other grant structures to kind of see how we can continue implementing this here in Omaha. So
What does the 92 cover?
the 92 covers staff, the
How many?
Incentive.
How many?
Yeah, so it covers staff, incentive, which we do every week for 120 participants. Also the dashboard, which is where a lot of money going to. It involves weekly analysis and updating the dashboard. It also covers that. I must also say that because it started in St. Louis, Missouri during my postdoc at Washington University, there is a lot of partnership where the dashboard is extremely discounted, the cost of it for us. The other sites like Colorado, Texas, they have a budget of about $176,000 for the same thing, but mainly because of the dashboard and the cost of maintaining it. But we got that discounted.
So you have some social media handles.
Yes, we do.
Can you make those available?
Oh,
to
yes,
us?
I could.
I'm assuming, can you make the presentation available to us after this?
Oh, yes.
Okay.
Can do that.
Let me ask you, so, okay, you've been in 32 weeks. You said it started at WashU in St. Louis?
Oh, yes. The initial I-HEAD program started at St. Louis, Missouri. But then when I moved here, I started the Omaha version.
So you started it in WashU in St. Louis?
Yes. So we had I-HEAD St. Louis.
So is it like it feels like a franchise almost?
It's like a research with multiple sites. That's the way we say it. Like a split site research thing.
So you started in St. Louis, you came here and you started it. What does somebody in like Colorado have to do to start it?
So because St. Louis is funded by the NIH, it's part of a SEAL, the Community Engagement Alliance grant.
Yeah.
So they also got that grant in Colorado and Baltimore, and they decided to also join the St. Louis system. So currently St. Louis is the coordinating center, and then they're also reaching out to even people that are not part of the SEAL network to say, hey, this is what we're doing. So
St. Louis is the hub because you started in St. Louis and you brought it because
Yes.
it's yours, but then.
Oh, no, it's not mine. So I have people that I work with.
Okay.
So I was just leading the effort in
Okay.
St. Louis.
You were leading effort, okay.
Yes.
Okay.
But then there are other people in St. Louis who do this as well.
So Colorado, all the other places are kind of working off the same grant that St. Louis is, so it's just an extension there.
Yes.
Okay.
Although I think New York and Georgia, they would be getting funded through another means. They didn't get the NIH, but they are interested, so they are getting it through sourcing their own fund.
So how do you get on the trusted leaders list to get this?
So that's a very good question. We worked with the Douglas County Health Department. They connected us with some of the leaders that they work with, especially community health workers, people who go into the community. We also got people sign up through our social media pages. So sometimes we put it on social media, hey, are you a community organization? Do you need resources or things like that? So people sign up um, through that to a newsletter. That's been the way.
So you control the list? Are you doing it through, is that our support that you stated at the beginning, how we support it?
Yes, so we assist, so AO sends us information weekly. I send it out and kind of, if there's something specific to, let's say, I'm thinking the applesauce packets, the pouches, I sent that to LED and they shared out the information on our social media. So making sure that whatever information is heard, connecting to the right programs within the department and saying, hey, this is something that people are hearing, just want you to be aware of, here's the social media to go with it.
Okay. You should add the board to the list.
Happy to.
Okay. What, anybody else got any questions for her? Okay. What, I'm curious, explain to me again the part you said about the hindrance with the information being local and people not trusting it, well, not trusting it, but explain that piece again about the CDC being and needed to kind of brand it local. Can you explain that again? I got it, but I didn't quite get what the issue was.
So a lot of community organizations that we work with in Omaha, let's say maybe they focus on mental health and they need resources on maybe depression, or there is a free mental health service. They will have to go to the CDC website to look for health communication resources they can use. But the thing is, the CDC would only provide something that is generic, like it's not localized to Omaha. The data they use is not going to be for Omaha. They'll probably just say something like, do you know 1 in 5 Americans, this. So people, the organizations we work with have said, we want something for Omaha. We want health communication resources that can say for Omaha residents. And then we want to brand it not just with the CDC logo, we want our organization logo to be on it. Okay. So we do that for free. Okay. We put their logo, we use Omaha data since we collect this every week. We're able to say, do you know 1 in this Omaha adult said this last week, or something very recent and something also localized.
So it's not an issue of you getting the data, it's just based on their feedback, you're gonna reframe it in a more local tense and put like local organizations on it.
Yes.
Okay.
We also get local quotes. So sometimes we reach out to, because that's one of the things, we reach out to maybe physicians in Omaha and we could say, can you please comment on this? And then we create assets from that. So it's very hyper local.
Okay. Do you have an advisory council or something?
The flyers?
No, I said, do you have like an advisory board or something of that degree, or is it owned by the university system or UNO, or is it? Yeah, I mean, who technically owns it?
So it's more of an applied research thing. Mm-hmm. It's not owned by UNO. So it's like a group of researchers who decide to do something in the community, just like the other research and intervention you do in the community. In fact, we still see this as a pilot because there is a strong potential for it to expand. Currently, we just have like 120 people and our panel members. We can always expand beyond that. So it's just like a pilot applied research, community engaged research project.
So it's a pilot. It's kind of identified with UNO because of you?
Yes.
but it's not
No.
anybody can kind of get in on it and make it
Yes.
well. Okay. Okay. All right. Thank you.
Thank you.
So if I want to follow up with you, I just go to Leah?
Yes.
Okay. Okay.
Thank you.
Thank you. So Leah, what do you all do with the reports?
Right now, the weekly reports I just have saved. Natalie meets with AO as well, and we have like the the newsletter that comes out. Those are pretty much I just share within our team to get the information out to community folks. Is that what you mean?
Yeah, I want to see that report.
Okay, happy to.
Okay. Thanks. Anybody else? Okay. Thank you. That's interesting. I don't know how that was hiding under the radar, but I'm glad it was up. Item D, workforce development and update.
Hello. Well, thank you for having me. My name is Jennifer Morgan, and I'm here to speak with you about the workforce development program here at DCHD. So first I wanted to let you know that my position, the Workforce Development Program Director, is funded through the Public Health Infrastructure Grant with the CDC. And this actually has three main strategies and goals for that entire grant, two of which really focus in on the work that I'm doing here at DCHD, and then we are working on the third as well. But the workforce is the first strategy, and the whole idea is to retain, recruit, support the workforce that's there, bring in a strong qualified workforce as we move forward with the moving people into the public health sphere, and also the foundational capabilities. So that's the systems that are going to strengthen the processes and policies, all of this basically setting up the workforce to be able to do their best work and all of the great work that you heard about today. Really, my job is to help them be more efficient, do their work better, be the best that they can be so they can do that great work. My role is totally funded, and the only position that's required by the grant. And there's a lot, as we work through this, you'll see there's a lot of touch points with how my job would parallel in a lot of ways with human resources. I'm not technically human resources, but I do work in conjunction and collaboration with those folks. So when we started looking, and I work for Jamin, and so when we started looking at really the goals specifically for DCHD, there were three of them that we came up that were really salient for the position. First, we wanted to advance a people-first culture. The second was design and implement systems of growth, and then enhance the organizational sustainability. So when we think about the advancing the people-first culture, that looks like employee well-being, employee engagement, workplace flexibilities, the incredible commitment that this team has to their populations that they serve, being able to enhance that. Systems of growth are really the training and development issues, adult learning practices, really being able to get in and work and help people continue that learning mechanism. One of the examples that's going to be really salient and we'll look at here in another couple of slides is the onboarding. We're looking at the processes and the system of bringing an employee in from their first day to their last day of their probation, and what all takes into that growth process for them. And then the organizational sustainability, that is the utilization of the 10 essential services in all the work that I'm doing, and how that then also feeds into the work that everybody else is doing at DCHD. There's policy review and implementation, and also a big part of that last goal is building those really strong relationships with the team members, staff, supervisory team, and the senior leadership team as well. So as promised, the new hire onboarding, this is really the system of learning. And as I mentioned, we want to take our newest employees from their first day to day 180. So we formed a formal performance management quality improvement team and analyzed the current system and the current processes that we have, and we identified a number of gaps, and that's what the team is working on right now, is building out the stopgaps for those various gaps. One of the big ones that we really found was there was a lot of different pieces and places that things need to happen. So, right, we need to get a email and all the equipment, and there's a lot of disjointed on who's doing what and how it should be accomplished. So that's one of the things that the team is working on right now, is being able to say, here's all the things from an administration point of perspective, here's all the things that a supervisor needs to do, here's all the things that workforce development needs to do, here's senior leadership's task. So that way we have that all identified and documented. Excuse me. The other piece to that system, of course, is the curriculum. And out of that, while we are still going through those gaps, we do have new folks that are starting. And so we wanted to launch the new hire orientation class. We had our first one on April 9th. So we did an overview of DCHD, our policies, our practices, introduction to all the various teams, and really to set that foundation of who and what we are here at DCHD to give the new folks a good solid foundation. As you can see, I added the picture here. It was really great to work with these folks, and I think they're going to be a good addition to the teams. Another really great thing that I think is going to be really impactful for the teams here at DCHD was the telework agreement, or telework policy. We actually did a rollout last week on Wednesday, and Dr. Hughes signed the policy on Friday. I want to read kind of the intention of the policy, and we worked, again, it was a formal PMQI team that worked through this process to build out our telework policy. But the purpose of the policy is the intention and purpose of the DCHD telework policy is to encourage employee flexibility while maintaining DCHD's high standard of work and commitment to the people of Douglas County. So as we looked at the kind of the current environment and past iterations of a remote work or a work from home policy, we identified that we wanted that flexibility, but we also wanted to make sure that there was accountability, not only from the folks doing the work, but also the supervisors. And we wanted to make sure that everybody had the tools and the foundations to be able to make the telework work, both from that flexibility standpoint as well as that accountability. So in this, we actually developed some tools that staff and supervisors are going to be able to use, and we'll look at that in a couple of slides here, but use to really facilitate that communication and that building of trust, as well as ensuring that accountability. One other last point on that, we built into the policy, we're going to formally evaluate it at 6 and 12 months to look at how is it functioning as we expected? Is it being efficient? Are there other opportunities to improve? So we do have that formal evaluation built in. I did want to just say a big thank you to the team. They did a lot of hard work. We started in January. As I mentioned, Dr. Hughes signed on Friday. So great big thank you to this team. It was a privilege to work with them. So this is the example of the tools that I was just mentioning that are the communication tools that really we want to be able to use to help set expectations from a supervisory standpoint, but also facilitate that communication. So we've developed a work plan where we did really go in and ask employees to think about the work they're doing. Why is it important? Speak about that value. How does it impact the essential services or the public health competencies, what competency they're working on? But also, as you go on through those pages, there's room for, here's the tasks that I'm going to be doing, here's the time frame that I'm going to be working on. And so what this document is, they can take it into their meetings with their leaders and say, okay, these are the things that I'm working on that are important to me, all of that. The supervisor has the opportunity to say, hey, let's do a little course correction and head a different direction, or hey, this is really great. this is the priority we want. How else can I support you? So really these documents are to help facilitate that communication and, as I mentioned, drive that accountability from all levels of the organization. One of the other things that we just recently launched was the Learning and Development intranet site. So we do have, DCHD already has an intranet site that's in existence and utilized, and I really wanted a place where we could have a repository for all the different learning elements that we're doing, from our training courses to small micro learnings, which is a strong adult learning principle that I really like to embrace. Think like TED Talk Tuesdays or small snippets, quick hits for learning mechanisms, but having all of our training in one spot. And it was really great after we kind of launched this and set it out for the teams to start utilizing. Our ERC team came and said, hey, I've got this incident management training that we want all of our teams to go through. Can, one, we get it on the onboarding, and two, can we get it on the website? So we've got some really good collaboration across the organization, and I think as we start to use this more, we'll see more folks wanting to make sure that we've got everything in our centralized location. And then for the last slide that I have, just the continuing work that we want to focus on with the workforce development. So one of the next steps is we're putting together the strategic plan. Our current strategic plan is ending its life cycle, and it is time to start heading down the path of re-looking at that post-COVID. So we're standing up a strategic plan, and the workforce development will support that. Out of that strategic plan, we'd like to do a workforce development plan creation that will crosswalk with the accreditation domain 8, the workforce development, which does require a workforce development plan. So we're going to go in and update our current plan in line with the new strategic plan that's happening. Also, we're going to finish up this onboarding system. It's my goal to get a class to start a class that goes through the whole 180 days by the end of the year, so we get it all up and running. Very excited for that. And then we're also in the process of standing up a policy review committee where we're going to look at all the existing policies. There's a time frame on all of them to review and ensure that they're still meaningful. And so we're going to go through and do that. We're standing up that committee right now. So thank you. And if you have any questions, I'll be happy to answer them.
So Jennifer, I'm just curious, what's your background?
So I actually spent about 25 years in corporate. Corporate leadership positions. I worked for Fortune 500 here in Omaha, worked for a couple of startup companies, but I have my master's degree in organizational leadership, and that's where I found this passion for how organizations work and how people work within organizations. So through that practical application in the corporate world, seeing how that all works, it really tied together. And then I'm a doctoral candidate in industrial organizational psychology, which also focusing in on leadership and adult learning.
How are you all coordinating with HR?
Okay, I think it's on. So our work with HR has typically just been at like the chief and supervisor level. With Jennifer on board and some of the new people that are coming into HR, we'll be able to coordinate more. They've been short-staffed for a really long time, and so there hasn't been a lot of capacity for things like training, for the county level, orientation and things like that. I know that there are some gaps there that they have been working actively to plug. So as those people are hired on and start actually interacting with the agencies, we'll have more tie-ins with workforce development. At this point, a lot of our our HR is really has typically been, at least since I've been here, has more been focused on really hiring, employee performance, things like that. So we're still building that.
Well, I meant more like you all aren't operating a vacuum. I mean, they know her role, what she's doing, because it's, yeah, I mean, they're building up, they're kind of on demand, but you all are doing some stuff that seems like bigger than the health department.
Most of the things that we're doing are health department focused so far with workforce development, but absolutely there could be a tie-in with.
But I just want to make sure
the
that
bigger
they're
work.
not, you're not, I mean,
No, they know.
They're familiar, okay,
Yeah.
okay.
We worked actively with them on the position description and hiring and title and all of that, and they're aware of that we have someone in the position and the work she's doing.
I'm just curious, I remember the grant when it came, but what was the qualifications to get this? Because I'm assuming we're the only one, are we the only department in the state that's got this?
We are, although I believe the state also got funding, so they would also be required to have this position.
Okay.
So I don't know who that is or what that position looks like necessarily, but everyone who got this grant was required to hire a workforce development director.
So I'm assuming you had to be over a certain size department.
Yeah. So so Douglas County was the only community in Nebraska eligible to apply independently. Every state was awarded this grant, and then you had to have a population of over 400,000 to be able to apply independently. And then the purpose and the function of the workforce development director or coordinator is to help to support sustaining and building a 21st century public health workforce. So strictly focusing on making sure that those 10 essential services are built into the way that our department operates, the way we onboard, and then the way we retain those skilled practitioners.
Okay. So the state, we're doing ours because of size, but I'm assuming the state's taking some responsibility for every department.
Other than us.
Yeah.
And I
themselves.
honestly don't know what that looks like at this point because we're kind of doing our own.
Well, no, don't worry. I'm just curious because I'm just curious.
Yeah. So we share a project officer with the state. We meet with the state monthly. The state, one of the requirements of the state was that they distribute 60% of their funding to the local health departments that didn't receive this.
Okay.
We recognized that we have a unique opportunity to partner really well with our other local health department partners and to coordinate the work that we're doing. And so we are working really closely with the state. Some of their grant objectives look a little bit differently than ours, and they have to because they have to meet the needs of rural communities. But I would say that there's a lot of coordination between us and our state partners, and we do meet at least monthly.
No, I was just wondering because the whole purpose of it was to build capacity after COVID in the future. Okay, all right. I'm good, thank you.
Awesome, thank you.
So when you're taking a lead on strategic planning, so?
I'm not taking the lead, but I'm going to support the effort.
So I'm assuming we're going to get there.
We are. So we, had opted to kind of step back into our values and ensuring that we're all in agreement and solid and understand who we are before we move back into that strategic planning work. So that work is just wrapping up and we'll launch it in May. So you're going to hear lots about this at the next Board of Health meeting. I will just give you a little spoiler here that it looks similar to, what our back in 2017 or 18 when this work happened and sat down and figured out what values we have and all of this work. It's similar. It's just, I think, reworked and reworded with different emphasis. And so the strategic plan will come kind of in the second half of the year. So the board, we had planned to bring the board in for strategic planning as well. So you'll be part of that process.
Okay. So I'm assuming too, overall, your position with the policy stuff and everything internal, it's not only its position, its capacity, it's trying to reduce turnover, its culture, it's the whole thing.
Correct.
So no, there's a question there on it. I just wanted to make sure to the question that was asked, on Zoom. My question was more so just to make sure you all had some tie to HR, because this is, you almost got the strength to be on you're kind of doing your own thing, but I just wanted to make sure they were aware of it. So to the question that was asked, HR's capacity won't hinder this. As long as HR is familiar with it and tired, everything is good.
Yeah, and I want to reiterate, like, we're very intentional about saying this is not an HR function. There are some similarities and opportunities for great partnership. We cannot function without Douglas County HR. We recognize that, and we're not trying to duplicate any of the work that they're doing.
Okay.
We simply recognize we can help to support their work internally to make sure that we're building that strong public health workforce.
Okay. All right. Got it.
Thank you.
Thank you. I will, let's go to the department reports and updates. Does anybody have any questions on those? Okay, could somebody put us back in the gallery, because I got a question for Justin.
Justin is out of the country right now.
He is.
So if
Question
I
come
can
to you?
answer it, I will sure
Yeah,
do
I'm
that.
just curious about the that outbreak section under his report and the measles numbers. That whole thing about measles, CDC, 130 cases. I mean, our name's not mentioned, but what do you see that, and is that something preventative we could get ahead of?
So, yeah, that's definitely something that we're keeping an extremely close eye on. And in fact, we do get calls somewhat frequently from providers asking which tests to run because they suspect, they have a suspicion of measles. Luckily, we haven't had cases yet, but it's probably a matter of time before we have a case. The best thing that can be done for measles is to be vaccinated. And so, what typically we see with measles is that people travel to measles endemic areas or areas that have lower vaccination rates where measles is able to kind of take a little bit of a foothold. And if they don't have immunity, either through a natural infection that they've had or through vaccination, they can pick that up, and it's highly transmissible. Something like 95% of people who get exposed to it are going to get it. It is incredibly infectious. And so we know, and we've known for a very long time, that the measles vaccination is extremely effective. It's safe. It's one that has been around for years and years and actually has been subjected to quite a bit of scrutiny. And so we continue to encourage those MMR vaccines. And we are lucky here in Nebraska. Our rates are fairly good here for vaccination rates, especially in our school age population. So that is going to be helpful for us. But we also want to ensure that people are continuing to get that vaccination for their children because it is safe and effective. Measles can be it can be deadly for kiddos, so we want to prevent that as much as we possibly can.
So I guess the CDC will start jumping if they see anything, because I'm just seeing these states, and it's like, so we're counting on them to ratchet it up if anything jumps out there.
Right. And, each of those communities is going to have teams like ours, the epidemiology teams like ours that are doing surveillance. Each of those states are doing surveillance and are implementing control measures as they are able to in those communities.
Okay, seeing no questions on reports, we don't have need for the executive session, and nobody's expressed need for the May meeting, so you can cancel that. But please do plan for the June meeting. And other than that, I got a meeting I got to go to next month. So you'll have to run the meeting. But I'll plan to be on to try to see the state of public health. So
I'll make sure we get like a good 10-page long resolution for him to read.
Hey, all right. But other than that, is there a motion to adjourn?
So moved.
There's a motion. Is there a second? Motion by Wilkins. Is there a second? Second by Weiss. Roll call.
Yes.
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 Thank you all.